Hi, good afternoon. Welcome to this ICTUSNet webinar. As you know, this is a series of webinars that we are having with the different regions in an ICTUSNet project. These webinars are basically meant to provide you with the results of the analysis that we've done with your data. Basically to analyze the care provided, the process of care provided to your patients in the region, today in the north region of Portugal, and then give you insight on the methodology that we followed and the comparison with the other regions. So we've prepared this webinar in 4 slots. So in the first one, we thought that might be of your interest, and I think it's good to get into detail of the methodology that we followed. Not always is obvious how this methodology applies and what are the let's say possibilities that the methodology does have. What are the limitations that the methodology has? So we thought that the very first slot of this webinar should be oriented to provide you with sufficient insight for you to assess the ability of this methodology, to provide the results and to provide the insight that you need to make decisions. And then there will be 3 more slots. Now you're more focused on the actual results, the comparison with the other regions in ICTUSNet. So it's important for us to understand the methodology to see how to compare with the other regions, in particular with 2 regions that we've selected as the best practices. So you might end up comparing your results with them both. We are doing the same with the other regions, both in terms of methodology and the data behind the results, but also in terms of the results. And then there will be a discussion on the way forward. So in terms of whether we could improve the analysis using this methodology, but also in terms of what should be done in the north region of Portugal to improve the care provided to the patients. Just keep in mind that we are focusing on what is the care provided in the emergency departments and in the hospital settings. So even though at the beginning the scope of this analysis meant to be more broader, in the end we're focusing today on emergency care and hospital care. And also keep in mind that what we want out of this conversation today is shedding light on how to improve care in the different regions by comparing with the other regions. So thank you very much for joining today, and hope you enjoy and this time together sheds light on how things are happening in Portugal and how we can improve the care provided to ischemic stroke patients. Thank you.
So this is the report for North Portugal for 2019. As you can see, there is not many activities with a time span available. Just the admission to emergency care, discharge from emergency care, admission to hospital, and discharge to hospital. That renders results that are as expected, but with few information, not very much information. This is the information you can get basically querying your database. So the process is not very much informative here on what is happening. Maybe this is a little bit more informative. Median times between the nodes are great to have, but also as the information on the episode is few, is lacking, these median times are not very informative. We can observe the change in these median times between 2019 and 2020. Sorry. But there is not much to say here also. There is an improvement in the times that can be seen from a little bit improvement from 4.9 to 4.7 in 2010. The same goes for the episodes classified as ischemic strokes that are just a subset of the tab before. For 2018 and 2020, is the same. And regrettably, for Portugal, we were not able to identify hemorrhagic strokes. So I will go through why could that be. It's the same also for, sorry, I'm playing with a Zoom. It's the same also for 2020. It's also the same. And as little as these results may seem, apparently, I would like to go through the journey of how we have come up with this and what we can do to improve it. If you let me. So I will start at the beginning. That's all that I'm going to tell you. It has to sound familiar to you because you have been participating in the process. When we set up this process in order to analyze or mine the acute care of a stroke process in the different regions, we set for a wide definition of a stroke case. That wide definition included all strokes, all patients with a stroke diagnosis at emergency care. Was a confirmed stroke diagnosis or not? Yes, with a stroke diagnosis will go in. And all patients who were admitted to hospital with a stroke diagnosis. And we made it that way in order to see whether a patient with a diagnosis of a stroke and emergency care will always go to the hospital, will always be admitted to the hospital, or the other way around. If a patient admitted to a hospital with a stroke diagnosis were previously always admitted to emergency care, or were always going through emergency care prior to the admission. Okay, that put us with a difficulty in the selection of the patients, but also in the selection of the events that we were taking into account. So if we selected the patient that was admitted to a hospital with a stroke diagnosis, for that patient, we should look up all his or her admissions to emergency care, and also the other way around to have the complete picture. Okay. We also started with the definitions to define the subset of patients and classify them between the diagnosis of ischemic stroke, hemorrhagic stroke, and transient ischemic stroke. We used the diagnosis codes. So if the main diagnosis was a stroke and fall within the codes on ICD-9 or ICD-10 corresponding to the ischemic stroke, that was for us an ischemic stroke patient. If they fall in the diagnosis for the hemorrhagic stroke, the same. That's how we classify the hemorrhagic strokes in the outputs, in the results. Our approach for the first time in an European project that we have encountered we choose to go for a federated approach, for the federated infrastructure, but also came with some burdens that we have to manage. First burden, if I may say so, also it could be so as an advantage, is that the governance should be federated. So decisions should be made between partners. That's the way it is. So partners, although there is a central hub that is promoting or pushing forward the research or the analysis, partners should be considered equal. So they have to have the capabilities and the ability to conduct the research, both in terms of data, resources, and human skills. So that was one thing. Another advantage we have in the federated was that all the analysis we were doing were privacy preserving by design. Any data were out of your premises. What we wanted to move was code, the scripts, the program, the software, and enabled you, give you the capability to use it in your data and transfer it to you finally for you to make the analysis that you wanted onwards after the project was done. So we have to get to the point you were able to run the analysis, but not only able to run the analysis, but understanding what the analysis was doing and being able to modify the analysis if you wanted. Here, I don't know if you can see my mouse. Yeah. Here I put the interim result we produced. That was a paper on this topic, on the use of a federated approach to the analysis of the pathways, of care pathways, that you can find. There is a link, so if you click in the slides, when you have it, you will find the article. So this is the image, this is all we have been talking all the time. Every time we talk each other, we talk with this schema in mind. So as you know it, I'm going to advance step by step in which various difficulties and problems we have faced in this journey that we enter when we enter the task. So first was the data, and we come up with a very minimal common data model. We found some issues with that. If you remember, the first time we reached you with a data model, that was more than 1 year before, we were in version 3, and by the end of the exercise with each of the regions partners, we are now in version 13. So 10 versions has passed. That versioning has been produced by encountering difficulties for the partners to get the data to the format that were needed for the analysis. So we iterate with each partner, looking at for the data sources and looking at how they were storing the information at each instance. So for example, when we reached you out, we learned that you did not only apply fibrinolysis within the emergency care, but you did it on the hospital admission. So we initially didn't have the fibrinolysis activity, fibrinolysis time within the hospital data. We added because you and also people from France told us that they were doing the fibrinolysis within the admission, so that we needed to add that variable there. That was important because first, hospital records that did not record fibrinolysis time specifically, but should be inferred for the procedures of the hospital admission. So in order to have that timestamp there, we had to come up with a way to assign the procedure time to with the fibrinolysis to the fibrinolysis time.
What Paco is highlighting is the fact that we can develop a single model for each of the regions, which in the end means, well, let's take the information that you have and do the process mining. But the beauty of international comparison is to have a common data model. And when you build a common data model, being common requires a minimum common denominator. So things that you can compare to. So there is a compromise between the granularity of the data in the different regions and the actual capacity to do common things. And this might be the case that we thought we can have, and also the point that, and this is the second element, one thing is minimum common denominator. The second one is, well, but there is different way to do things in Portugal than in Aragon, than in France. For example, you register the fibrinolysis job in the emergency care, while in Aragon or the other way around, is registered in the hospital admission. But in the hospital admission, there is no clear date, a timestamp. So you have to figure out how to allocate fibrinolysis and timestamp within the discharge, within the admission, instead of in the emergency department. So things that relate to the availability of data, things that has to do with how to account for data when you are aiming a common data model. So if we are aiming a Porto data model, then we might think of differently. So please, Paco.
Yes, so important lesson here is we try to make it the minimum, the bare minimum, in order to achieve the exercise, because we were at the beginning worried about the feasibility of the exercise in terms of transferring the technical capabilities in order to get the exercise done. The success story there is that we have made it. The only region that has not been able to complete the exercise has been France, Aquitania, the French region, and not because of the tool or because of the software, but because other things, other questions. So if we advance, you have problems with data completion. There is not much data available in a structured way to complete the data model. But the main problem we also encountered was with the data format. As for the structured data, you rely in health information systems that are formatted and coded in a way that was at first not interoperable with the format we were proposing, even after we updated the data model iteratively multiple times. So at the end, we had to come up with a specific solution for Portugal that was Mapper, that was creating a software that could take the inputs of the data from Portugal, from the different entities, emergency care, contacts, and hospital episodes, and patient information, and map that information to the format expected by the data model.
Mm-hmm.
That worked more or less okay, but was with caveats. And main caveats was some of the information was lost in the mapping. This example data. So it's just random data we generated in order to see if the mapper was working properly at your end. And he marked whether the information was lost, but that information was lost precisely because it was not needed for the analysis, and it was required to be deleted in order for the mapper to output something that we can ingest within the process mining. So it was some downs and ups that we get to the point where we can could proceed with the analysis. And I want to highlight two things. First things is that we with this experience we generated the mapper, and the mapper is a software that is already available, and we can keep improving it in case of need. And the other thing I want to highlight is through this process, there has been some lessons learned both for us and I think also Hugo, that had put a lot of work in formatting the data. And I think that that is a real gain in terms of whatever the results that not allow the comparison, the international comparison, or the comparison between regions as we would want it. The process is possible to do at the local level, at the level you want it, with the data sets you are able to get and to fix. So just for you to consider that the mapper is there already as a result of this work, and that these results may not be comparable with other regions, but could be extended locally as far as you want to. So continuing, this is something I have already talked before, but here I want to center on the availability of activity data, and particularly on the timestamps. And that was the main point of this exercise. The bare minimum of activities you were required to have were the four you had: admission to emergency care, discharge from emergency care, admission to hospital, and discharge from hospital. That was the bare minimum required by the model in order to work and produce something. But there were up to 14 activities that you could have or can register within the common data model in order to get the results, to get the whole process. We will see later when we compare the results with the results from other regions how that activities play out. Another important thing was at the granularity of the times in the timestamps. So the first versions of the model allow it for full granularity. It means hour, minute, and second in the emergency care, and only date granularity at hospital care. And that was based on the first initial survey at the beginning of the project we did, whether partners commented that they didn't have hour, minute, and second in the hospital episodes, but only the date available. Some of them, for some regions, it was available, but it was not available for analysis. For other regions, it was not available, and that was all. with the progression and the iteration of the models, one we learned in building the analysis was that the process mining package or tool we were using, when finding two activities with the same date, with the same granularity, okay, order them by an arbitrary order. That could be alphabetically, or could be predefined order, or could be whatever you put it, but not the order of the activities. So in order to surpass or overcome that issue, we updated the data model, allowing for full granularity, both for emergency care episodes and for hospital care episodes. Okay. Independently of you were able to comply with the full granularity or not. Or for example, for the case of Aragon, we store within the hospital episode the full granularity, even minutes and seconds, but we don't have it available for analysis. We only have the date. So in the case of Aragon, hospital episodes are only stamped with the date. And so we had to come up with some arrangements in the order of the activities that was pre-recorded. Okay. And that the last point was already mentioned, that the lookup of the events required to look before and after the patient were selected. So an interesting patient, that means a patient with a diagnosis of a stroke, located at the hospital admission. We should take that patient and look for any emergency care contacts previous to that hospital admission, and the other way around. The patient located with a diagnosis of a stroke in emergency care, we had to look forth to any hospital admission that patient may have had, in order to see if they were admitted because of the stroke or because any other thing, and the stroke diagnosis was confirmed at the hospital or was not confirmed. So this is how the data model looks. It seems more complicated than it is. It is really only 3 elements, but as we have, for example, information regarding the country or region for comparison, we have to add some dictionaries. We also added some dictionaries in order to know from where the patient comes and to where the patient goes. That was the type of discharge and the type of admission. So in order to link the episodes, the important thing here is not to have the information of the patient within the system, but to have the ability to link the episodes, to link the episode of emergency care with the hospital episode and the other way around. So in order to do that, we created 2 pieces of software. One was the event log builder, that was the tool for coming up with these integrated episodes, considering both emergency care and hospital care, and the process mining pipeline, that was the tool for the analysis of that information to get to the outputs, to the results, to the process discovery. So these tools were created as software using both Python and R software. And the barrier we had here, and another point for the feasibility of the project, was that they were not easy to use. They require some technical knowledge, both in order to deploy them in your systems, and after that, in order to run them. due to this learning that we made in the interlocution, in the dialogue with you while doing the analysis, we have made progress through an integrated tool, a software tool that has a nice user interface that we can use to input the data and run any of the analysis we want, and we are working right now in the development of that tool. So that's also a progress we have made as a derivative of this process. Anyway, the software we have already produced is open source and is freely available in these directions, in these links, both on the Docker Hub and in Zenodo. Here I have to take a minute to highlight one thing. At the beginning, we were very keen and sure that we will be able to develop only one version of the software tool. We were that naive at that point, and the first thing we encountered was that some of the partners were not using any Linux or operating system or any Unix operating system. So what we did was be more humble and create another version of the software in a virtual machine. So the two versions that you are seeing here, with my mouse, this and this, this can run in any system except Windows. And this is the one to use if you have Windows. So that also was a problem because this version requires for you to first deploy a virtual machine, and within the virtual machine is included all the software for the analysis, but you have to deploy the virtual machine first and map the directories, the folders needed to the input and output with the folders in your computer, and that was not easy. Hugo can testify about that. We take some attempts to clear the field and to complete that process.
You can improve it, you can adapt it, you can do whatever you want to do with that if you want.
Yeah, software is under Creative Commons license. It's only international attribution, so you can do whatever you want with that. Also, as a result of the struggle we have with the different regions, we contacted the developers of the Booper package in R, and they were very helpful implementing new functionalities we suggested. So they are open for discussion, and they were able to already implement some of the functions we feel we needed. So that's also open for them. So we get to the results already known. This is the example for the 2019. The important thing here is, as we said already, not that we gain many information or more much information that we have already on the structured processing in Portugal, but that we could gain the ability of compare with another regions.
Just a second. Yeah. So imagine if you were able to have the 14 activities. So this graph that is very simple will turn into a spaghetti graph, so which is the name. So then with more granularity, you have more opportunities. I think you have this. So on the left-hand side of this image, what is presenting now with the mouse, there are the 14 activities. So this means that a proportion of the patients that are present in these data sources that provides these results, a percentage of them are going throughout the first track, the second, a different, another amount of patients all for the second track, a percentage of for the third track. So there are many tracks. The question would be, are the patients the same even though they go for different tracks, or are different patients going through the same track? This makes the question for further research. Go ahead, please.
Yeah, and we will be able to see that kind of questions that we can ask after we see some comparative results. This is your results as we have already seen them directly in the repos. I'm going to go through them just to show this. This is a main result in terms of visuals. There is very much analysis to do here, and each of these figures that I have selected from the different reports of the regions. There is much to say, but you can see that there is some heterogeneity. Main thing to mention is that all the regions in Spain are using data from 2017 because that was what we agreed in the beginning in order to be comparable. And here we have Portugal for data for 2019 and 2020. So it's just not comparable in terms of data. But also you can see there is a lot of heterogeneity in what the region has been able to do with the data. For example, we have the example of the Balearic Islands, when we encounter some difficulties, first of all, because only one hospital, the data from one hospital was available. And that was a referral hospital for stroke care, and they organized the acute or hyperacute care of the stroke very different of any other hospital in Spain. So they were in the conversation with them, they were introducing things in the data model, and also they had some difficulties to even retrieve their own data to comply with a common data model. So there is a work in progress with them that we have advanced farther than this, but this was left as a good example of how heterogeneous, how complex the mining of the data could be for the different regions. The point here is that if we could sum up, we will see that the activities are shared, so we can check whether two activities are connected or whether there is a trace that is common. Here we choose the performance, the process map performance that is with the times, with the median times. So we can see the hours that pass between one activity and another. The median time in hours from one activity to another from the different regions for all the patients with a stroke in a year. This analysis can be, the scope of this analysis can be widened. We choose to get data only for 1 year. We choose to do it from 2017 because it was the first year most partners have some good data. Although on retrospective, it might not be the best year to get it. Maybe for the feasibility of the analysis, that's okay, but we should do it with the most recent data in order to have a better understanding and insight of what is happening right now. But the analysis can be extended at any data you have available. Okay, and following the example of the comparison, I am just letting Portugal and Aragon just for us to see let me see if I can share the screen. Okay. Yeah, you are seeing my screen now? Yeah. Just as an example, the first iteration of the results for Aragon. Okay. Here, I'm not sure how many activities are there, but
12.
Yeah, 12. That may be because we didn't have here the thrombectomy. It's not here. That was the first result we got for Aragon, in which was based all the analysis. And as you can see, there is much information you can gain when you have the information available structured in order to input it in the data model. Where you can observe if the different tracks or traces or pathway a number of patients follows. For example, in the first case, 25% of the patients go that track, including an emergency care admission and discharge with a pass-through observation room within the emergency care. And here we have emergency exit because we're in Spain, we record the physical exit of the patient after or before the emergency care discharge, but this is not important. But they had some sort of admission and discharge. These two would be the most common ones. It is important to know that here we are not showing in the analysis all the possible traces. We are not showing the 100% of the sample or the patients within the sample, because that will make it very difficult to interpret, and the figure will look somehow confusing. But this is an important point, because the point is, with only this number of traces, you can get the 95% of the activity. Whether you see this same number of traces for other region or not indicates how standard their pathway is within their system. So for example, in Catalonia, we observed that with the same number of traces, this is not the example, but with only 15 traces, we cannot get to the 70% of the activity. So there is a 30% of the activity that is highly heterogeneous. That means patients going through pathways that are not typical, that are completely infrequent. Maybe that only that patient follows. Okay.
Yeah, this is really interesting, because you might have seen that in comparison, Navarre and Aragon, they have more or less 12 activities. So comparing both, there were those with more granularity. If you compare the percentage of the one, okay, you can see that the number of activities, so the red boxes are the same. But if you go to the traces, the next slide. Next.
So yeah, no, sorry, I didn't put that all the traces for all the regions, but only for Aragon.
Go for Aragon. It's no problem. It's just to highlight your point.
Yeah.
So maybe you can zoom it up a bit. So you can see that the first two traces correspond to the 48. So the first traces, 58% of the patients go through three traces. So this is one element to compare. So within this 95% of potential patients represented in here, 3 of them are more than almost 60%. If you add 2 more, you have 75% represented in C tracks. So following those tracks now, you can compare with the normative, with the theoretical pathway, but you also can compare with the others. How many patients, what Paco says, how many patients in Catalonia? Most of them are, you know, very small number of patients throughout. Is this personalized medicine, or is this just that they are following random paths? And then what happens with the next 10% of patients? So the last, those at the bottom of this graph, those that are so infrequent, are because patients are strange patients, or because the system has not reacted properly, and there is a back and forth, back and forth, back and forth. There is some rationale behind or not. So just taking this and analyzing this graph, you internally in Porto, you can have a lot of information if you have this granularity, of course. With the granularity that you have right now is difficult.
The recorded rate of fibrinolysis for ischemic stroke patients in Aragon in 2017 was 6.9%, okay. and we are capturing here within the most frequent traces 5 point something. So almost all the fibrinolysis done in that year.
We are talking about ischemic stroke, right? But we are covering the whole process, so implying that some patients, although the code stroke has been activated, in the end, the CT scan said, no, this is not the ischemic stroke, so it's not eligible for fibrinolysis. So this is why the first, so the 10 plus 10 plus 29 plus 33, so almost 80% of the patients, if I'm, yeah, most of 80% of the patients where the code stroke was activated in 2017 in our region were actually no ischemic strokes at all, or were at least were not eligible for a fibrinolysis treatment. Is this a question of we have not the fibrinolysis treatment available? First point. Second point, is this because they arrived in the hospital too late? Is this because they were in the hospital for too long before they got to the fibrinolysis? So a number of questions are raised now here, okay? We have to discount for the, this is one point that raised Paco that has to be in terms of comparison. Depending on how the procedures were implemented. So if, for example, Catalonia started thrombectomies in 2005, the learning curve has already done, and then they are approaching thrombectomy for everyone that is eligible everywhere.
Just as a wrap up, what we envisaged in the beginning for you to have was to participate in this comparison with all the data that you have available. Regrettably, that data was not very much, but we could complete the process with a lot of work on your part and a lot of patience. I will be always grateful for the patience you have had with us as we try to deploy the software. And I have to say the software is not very friendly to use, so we are, as I already say, trying to improve that. What we envisaged was for you to have this kind of results. These are some results for Aragon, and use these results for two things. First, complete the comparison with other regions in the IACS project, but most importantly, in order to prompt the dialogue with your healthcare professionals, not only the neurologists, but also the emergency care doctors, nurses, the radiologists, all the people that were participating in the hyperacute care of a stroke, from the ambulance that take the patients to place, to the first hospital that assists a patient and has to transfer to another referral hospital, everyone in the chain, in order to have the insight that they are equally important in a time-sensible process, and then we can look with this perspective to the whole process in order to improve it. And that could be made now just using the tools we have developed during the process locally. And our intention is that you go with this analysis or some similar analysis the farthest you can go in order to improve the process of stroke care in your region, as we are doing in our region with our professionals. So just to say that, and to present what we are thinking on in order to make this happen. As I said previously, we contacted with the developers of the package Bupa that is the one used to come up with the analysis, and we asked them for new functionality, and we have learned to use it more efficiently at the full capacity. So we have come up with a prototype of new analysis that could be implemented with the software already available. We have already produced, just updating the analysis file that has more information on the process, information on the frequency of the activities, information on the real timeline of the cases happening during the year or during the years. Okay, that will be this information. The rate at which the strokes are coming, and you can say some seasonality, for example. But you can see also changes in the throughput time, in the time the patient takes from entering the emergency care service to being discharged for the hospital, for example, and how that changed during the year, in this case, or not only focus on the frequent pathways that would be here in the left side, sorry, not only focus in the frequent, but also focus and try to see what is happening with the infrequent. And as I said before, these are all traces followed only by one patient within a year. So they are very rare, and they could be signaling maybe problems with the data, or problems with the information systems, or maybe problems with the pathway. And if there are problems with the information system and with the data, this is part of the culture of the organization. There are things we have to improve, and professionals should be aware that the data is being reused to generate results and to improve the practice. But if it's a problem with the pathway, we have to take care. We have to improve that process. We have to make sure that it is not happening, or that this doesn't mean harm to the patient. Okay. Or checking times. And for example, here on the left, we can see the throughput time, how much time the patient takes to complete the process, the complete process, any pathway they follow. Okay. And how and that can be disaggregated between ischemic stroke patients and hemorrhagic stroke patients, and by hospital. What you are seeing at the bottom is the attending hospital, the assisting hospital. So with enough granularity of the data, we can go deeper in the analysis and see what is really happening within the healthcare system and even within the hospital. So this is what we are aiming for in the near future, and what we are working for to get for all of you. Just one more, as the reaction of the neurologists was to focus on the fibrinolysis and how they were doing, and if the patients were reaching the hospital in time, and if they were eligibility issues derived from accessibility. For example, here in Aragon, we have a region that is poorly densely populated, and region, how do you say, small hospitals have not all the facilities. So patients have to be transferred across the region, sometimes long distances. They were very, very interested in this result. So this is the distribution of the time patient for taken for those patients from the code stroke activation to reaching to getting fibrinolysis. Okay, and you can see the median and 75% are within 90 minutes. That is the recommended expected time. Okay, but you can see also there are some outliers, and we can link here in Aragon, we can link the result of these outliers, these outliers in time with their results in terms of health. And you can see the same analysis by hospital. And just compare. So this is what we have to offer. And I want to close my presentation with a little bit of hope, is that to say that you can do it in terms even of data. As we were working with Joao and Hugo, and I don't remember if it was Hugo, I think it was Hugo or Joao, come up with a solution using their own Power-based system and the data in the format they already have it to get this result, this approximate result that captures all the essence of all the exercise that we are doing, just not the comparison. So this is just for me to say we are not there. We have some hard way to go forth, but we can achieve it. We have the tools, and it's
yeah. Thank you very much, Paco. So thank you very much. I think it's been very inspiring, the reactions from the I think there are elements from the, let's say, the promise and the hope, which is what we are now paving the way towards it, and the reality that in some places there are some difficulties. Many times it's a question of governance, many times it's a question of priorities also. But at the same time, just for you to know, here in Aragon, where we are, some 7 years ago, we decided to more or less, we decided to build. So we are actually an institution that is part of the Department of Health, the Regional Department of Health. It's an institution for science and research results translation, which in the end has a component of research, as we are scientists, but we also committed with the translation of science and methodologies into decision making in the region. So and because we now for more than 20 years working with the secondary use of existing data in the region, we suggested to as part of the portfolio of the institution to build a learning health system in the end, based on the reuse of all digital data present in the region. It's a quite wealth environment in terms of data and in terms of their capacities that we do have in terms of IT computing guys and so on. It's true that it's not maybe average in Spain, but the point is not just having the capacities, is the willingness to develop it and to pave the way, which means in the end, think of the learning system as a compound of governance rules, a compound of technological interoperability rules, a compound of interoperability, semantic interoperability elements, a compound of good science, and the translation of this good science into decision making, which is not obvious always. And well, I can say that we are actually now for 2 years, and we've been there is a real let's put it this way, data lake with 1.3 million lives, pouring the data every single day into the system. So collecting information from primary care, emergency care, hospital care, demographic, socioeconomic information. Now are linking biomarkers, linking genetic information out of the COVID pandemic. We have, speed up this process. So in the end, we do have 1.3 million lives with every single contact with the system. So the environment here is very, let's say, favorable to any development. But what I'm trying to say is that someone had, at some point in time, was the two guys that are present here today with you, had the idea of saying, well, all what we know could be converted in something that could be reusable for science, but for health services decision making. And this we got. So yeah, there might be difficulties, a lot of difficulties, I promise. We had, but we got having it. So there is a support by the regional ethical committee. There is a support by the scientists. There is a support by the health system. There is set up in law. So there is a regulation, which is important. There is a governance structure that governs decisions for research purposes, for management and quality assessment and improvement purposes, and also for teaching, so for training programs. I would say that, yeah, let's start with good examples. Process mining could be one. Could be not the best or the one best for the clinicians, but might be the case for decision makers in the region and in Portugal, and may take the opportunity, because we do know the guys from the SPS. So actually we collaborate. We are collaborating with them in different projects, so we are quite access to them, and so we can help if you want to implement this larger scale, if you want. Very much to you all, and just keep in touch in the upcoming months. So happy to have met you in this project. Be well.